Thank you, and thank you to the organising committee for the invitation to speak here. Sorry if I'm a bit husky. These are my disclosures, and while you're reading those, I'll just make a couple of comments. Given time, the primary focus of the talk will be around efficacy, the toxicity issues, both the tumour lysis, cytopenias, as well as the practical issues, so the logistics of administration have been published and well known, so I'm not wanting to diminish them, but won't be focusing on them. The second is I'll be talking about some MRD. All of that is flow and all using the 10 to the minus 4 threshold. And at some points I'll be using undetectable MRD rates to sort of compare across studies. I acknowledge that there may be subpopulations who are going deeper below 10 to the minus 4, so there could be a rationale for choosing one over the other, but I don't have data to support that. I won't be touching on the venetoclax BTK combinations. They'll be presented later in the meeting. And I'd been also asked to sort of express some opinion. So in a number of points in the absence of direct data, I'll be giving you my personal views. You may feel differently. Please feel free to disagree. It's now over 8 years since the first patients were dosed in June of 2001, and the longest patient on drug this November, a patient of mine will have been on continuous venetoclax for 8 years. So we're now getting some cumulative longer-term data. Andrew Roberts published earlier this year in Blood and aggregated the data from the early phase study. So a reasonable number of patients here, nearly 350. Given the sequence of development, nearly half of these patients had been exposed to previous B-cell receptor inhibitors, and 3/4 of them had deletion 17p, median 3 prior therapies, and median follow-up about 2.5 years at this point. So significant adverse risk factors. The median PFS overall 28 months, which very useful. But important element here, you'll see obviously the gap between the PFS curve and the overall survival curve. And one of the things that emerged relatively early in the venetoclax development, and Marianne Anderson spoke to this yesterday, mechanism of resistance and escape doesn't intrinsically or always involve a kinetically rapid relapse. So from progression, there can be a gap to needing retreatment, and as we'll come to, there is the opportunity and responsiveness to subsequent agents, hence the gap between the PFS curve and the overall survival curve. In distinction to the other classes of targeted agents that Susan had spoken about, one of the emerging early signals here was both a notable complete remission rate, as well as, even though this was unexpected in the phase 1 study, and so timing for collection was not systematic, but MRD negativity was seen early in these studies. As I said, data collection around MRD was not protocolized in the early study, so timing was variable, and these are the rates. There does appear to be a plateau in attainment of that, and as Thomas Liu from our centre presented yesterday, the majority of MRD negativity, at least at the 10 to the minus 4 level, is achieved within 24 months of treatment. This is the aggregated data that did include 49 patients treated with rituximab in the phase 1b study in combination, and these are the rates for the single agent venetoclax. So bone marrow MRD negativity about 10%, peripheral blood about 25%, although as noted these were ad hoc collection and not protocolized. It became, again, in distinction to the BTK inhibitors that provide very durable disease control in the absence of deep remissions as a single agent, here depth of remission matters. And even from these early studies, whether you dichotomize by CR versus PR at the 9-month time point, here the 24-month landmark looking at responders by MRD status. So deep responders with undetectable MRD here in the peripheral blood have a much more favourable outcome than those who have a less deep response at that landmark. One of the issues, we'd heard Andy Rawstron speak yesterday about preferred compartment to assess MRD. Certainly with chemoimmunotherapy, Andy's data showed there's nearly a log, about, I think his data was 0.8 of a log difference between marrow and blood. With venetoclax-based treatment, Pete Hillman may comment during the discussion, but the distinction between marrow and blood, there is less of a compartment effect. This was from the Murano study at the end of combination treatment, so at month 9, 3 months after the last antibody, looking overall at 90 patients, 90 paired marrow and blood samples, overall concordance about 85%, and of patients who were negative in the blood at the 10 to the minus 4 level, 90% of those were confirmed to be negative in the marrow. Thomas Liu has looked at our institutional data around what's the clinical impact or the clinical prognostic information provided by negativity in blood as compared to marrow. And in a practical sense, we feel that testing the blood gives sufficient information to inform outlook. Here in the left, the time to progression, so the blue curves are blood, solid is MRD negative at the 10 to the minus 4, hatched is those who are above that level, and red in the same coding is marrow. So both in terms of time to progression or overall survival, at least in our hands, blood is able to give us the same degree of predictive information as marrow, remembering that this is predominantly single agent, and if there are different antibodies added, particularly those that have more of a compartment effect, that may not be extrapolatable. So we saw Susan presented some data around differential outcomes by different biologic subsets. As I said, in the early venetoclax studies, very heavily pre-treated, particularly those who were either intolerant of or refractory to B-cell receptor inhibitors. And Andrew Roberts, in that aggregated analysis, performed a very thorough multivariate analysis looking at predictors of duration of response, and they're shown here. So nodal bulk was the most significant, but refractoriness to B-cell receptor inhibitors, TP53 dysfunction, and an emerging predictor that had not been identified earlier, admittedly based on small numbers of patients here, so only 26 with notch mutations, were associated in multivariate analysis with shorter durations of response. I note there monotherapy versus combination. This only included 49 patients from the phase 1b study, and at that point had median follow-up under 3 years. But with the data that was available then, monotherapy versus combination was not a significant predictor in multivariate analysis. If you then factor in depth of response, either PR versus CR at the 9-month or MRD status at the 24-month, those bolded factors, most of those retained significance. However, once you factored in depth of response, IGH mutational status was no longer significant. So that was predominantly single agent data. We then moved fairly rapidly based on preclinical synergy to a combination with rituximab in the phase 1b study. Earlier analysis had been published, and this is some data that Danielle Brander from Duke is leading and will be updated further and presented at ASH. But this is data from these 49 patients. As I said, this was MRD status was not systematically collected in the early studies, and this was the first trial to do so. And really unprecedented at the time, 61% of these patients attained undetectable MRD status in the marrow. This study also allowed cessation of treatment for those patients in deep response, and was the first study to test that paradigm of time-limited treatment. And there were 18 patients who elected to cease. So now with a median follow-up here of just over 4 years, the median PFS has not yet been reached and is looking very favourable. Now this is not a direct comparison because obviously there is a guarantee time in those who achieved a deep response. But this compares the time to progression for those patients who elected to come off venetoclax in the context of a deep response, or those at 12 months who had achieved a deep response but continued on venetoclax. Now this shows progression-free survival, and there have been 3 patients whose disease has progressed after cessation of venetoclax, but notably this is not duration of venetoclax benefit, because these 3 patients then were retreated with venetoclax. So of the 18 who had ceased drug, this is an earlier analysis from ASH 2018. Median time on drug was 16 months. At this point, median time off drug had been 34 months, so a ratio of about 2 to 1, but obviously the time off drug will continue to increase. This shows the 3 patients who ceased drug after between 6 and 9 months, attaining a deep response. 2 of them are CR but MRD positive, and 1 an MRD negative CR. And the time to progression is shown in these orange blocks. But then all 3 responded to reintroduction of venetoclax, 2 of the 3 are ongoing. So this defines the distinction between progression-free survival after withdrawal of drug versus the duration of venetoclax benefit with reintroduction. And that was the paradigm that was taken forward then in the Murano study, so a randomised comparison using venetoclax rituximab with the 6 infusions. Here, time limited at 24 months, so set for all patients compared to bendamustine rituximab. This has been published, and this is 4-year update data that was, thank you for people who came to the poster last night, and so presenting some of that here. Median follow-up here, 48 months, and we'll come to the data about the 130 patients who had ceased drug at 24 months and are now median 22 months off therapy. So at 4 years, 57% of patients on the venetoclax arm remain progression-free, and that hazard ratio remains comparable to the previous analyses. In distinction to single-agent venetoclax, and it may simply be a numbers or a duration of follow-up, to date we haven't seen any differential outcome by deletion 17p status, and this is some new data that Jenny Wu presented at Lugano this year, now looking by mutation analysis, by next-gen sequencing for a number of mutations. So again, as with the del-17p, within the venetoclax arm, so unmutated is the light purple, mutated is the darker purple, these are the venetoclax, and then in all of these curves, the bendamustine rituximab are travelling inferiorly. So mutation of TP53 has an adverse impact as expected in the bendamustine group, but not within venetoclax. P-value there, 0.22. Similarly for ATM, notch is a little bit complex. So the within-arm comparison, so venetoclax outcome, whether you do or don't have a notch mutation, here again with the combination, p-value 0.66. So there is no adverse impact with current follow-up for notch mutation. However, there's a treatment-dependent interaction such that the magnitude of treatment effect is lesser in those with the mutation. So you can see in the bendamustine group that the mutated group is actually travelling above the unmutated. So this p-value that Paolo quoted to you yesterday is actually for the interaction, not for the impact of the notch mutation within venetoclax, which was not significant. Arnon Carter had done a huge amount of work in people in his lab on array CGH because one of the gaps in venetoclax data had been karyotypic complexity, because stimulated karyotype was not included in the earlier studies. So here, categorization by no complexity, 0 to 2, low complexity 3 to 4, or high complexity 5 or greater. And within the bendamustine rituximab treated arm, you see a stratification with increasingly poor outcome with increasing complexity. Conversely, in the venetoclax rituximab treated group, there was no difference in outcome between those with no complexity or low complexity. However, those with 5 or greater aberrations had an inferior outcome. Overall survival is now becoming mature, and to my surprise, there's an increasing gap between those. So a 17% difference in overall survival at 4 years with a hazard ratio of 0.41. And that was despite nearly 80% of patients on the bendamustine rituximab arm receiving targeted agents at their next therapy. So to me, that reinforces that novel agents should be used early in the course of relapsed disease, and I don't see justification for multiple uses of chemoimmunotherapy in the relapse setting in the current era if they're available. So 130 patients had got to the end of treatment, and as I said, cessation was consistent across all. There was not any individualisation by MRD status, and this shows outcome according to MRD status at the time of cessation. So in the overall population, grouping everyone together, 68% remained progression-free at 24 months after cessation, and this is with a median now of 22 months follow-up after venetoclax cessation. But there's very clear stratification by MRD status at end of treatment, and probably most notably those who had high MRD, so above 10 to the minus 2, so above 1%, as Andy Rawstron presented. Perhaps we shouldn't be calling this minimal. Perhaps these patients are truly in partial remission, but nevertheless, this was according to current terminology. Over 90% of those have disease progression. Conversely, of the 83 patients who were undetectable MRD, only 11 have had disease progression, again with 2-year follow-up. So these are the progression-free survival curves from cessation of venetoclax. And clearly those with high MRD at the end of treatment do very poorly. And when I presented this data previously, the most common comment to me was, well, it was clearly inappropriate to stop treatment. These people would have benefited from continuing drug. Why did you stop treatment? One of the answers was, well, that's what the protocol said. But a second answer was, we then went and looked back. So this is the time of end of treatment, and there'd been 3 monthly serial MRDs while on venetoclax in the preceding months. And these are the preceding MRD levels in those patients who had high MRD at the end of treatment. And in all of those, it was actually rising on venetoclax. So yes, those patients did poorly, but I don't believe from this data that continuing on single agent venetoclax actually would have addressed those concerns. In the interests of time, I will skip over these slides. So why is time-limited therapy important? As Marianne Anderson presented yesterday, as with other targeted agents, and we're beginning to understand the mechanisms, one of which includes the development of mutations in BCL2 that inhibit the binding of venetoclax, and this is putatively induced by prolonged selection pressure and exposure to the drug. So small numbers of patients at this point, but the median time to detection of these mutations was 33 months, one of the drivers for preferentially using time-limited therapy in these patients. In the absence of direct head-to-head comparisons, how can we choose which agents may be preferable? Thank you to Anthony Mato for this slide that from one of his posters here, looking at a comparison of progression-free survival by first targeted agent used. And the reference here is ibrutinib, which is that middle black curve, not showing a statistically significant difference for venetoclax, but idelalisib in this comparison being inferior, which was not influenced by those other parameters. I'll skip over that in the interests of time and come to my conclusion. So my own personal views, and as I said, these in the absence of direct randomized studies, we need to make decisions as to what we do in our own clinical context. both in a biologic sense as well as I think now the data supports it. I do prefer time-limited treatment with venetoclax, and using in combination with an anti-CD20 antibody achieves deeper remissions in a higher proportion of patients and opens up that option for a greater number of our patients. Based on the predictive index that Jake Seymour had published in Lancet Haematology, and this was one that was presented yesterday, so I skipped over it, efficacy appears broadly comparable in the low or intermediate risk groups. My personal preference is venetoclax-based treatment in high-risk groups or those with deletion 17p if it appears to be deliverable. But there remain a substantial number of unanswered questions and genomic complexity remains an unresolved issue. There are putatively curative therapies, where they fit in the paradigm, what level of risk is sufficient to justify those complex, expensive and risky interventions remains unclear, and we'll be debating that later today. And I think a challenge for us is that the majority of previous prognostic factors in the chemoimmunotherapy era, other than deletion 17p, have far less impact in the targeted therapy era. But we're still seeing quite variable outcomes, and the challenge to us is now to identify which are the molecular and genomic predictors that are able to identify and stratify outcome, and are they the same between targeted agents, or is there a molecular or genomic profile that allows us to identify who may preferentially benefit from one class of drugs or another. Thank you very much.